Wonderful, thank you. Our next speaker is Dr. David Leung. He was a leader in nuclear medicine at Columbia. Now he's at Bristol Myers Squibb, where he's leading the development of functional imaging across tumor types, but with an idea of using particularly PET reagents, particularly as a biomarker of both response and actually potentially of predictive biomarkers as well.
Thank you. Good morning. So this morning we are going to discuss a little bit about development and potential of ImmunoPET imaging in how we can help our patients. So we will start with a chronologically arranged agenda. We'll start with how we position, plan, and execute our translational strategy, and also reporting to you the progress so far with respect to an example in our first-in-human experience in PD-L1 and PD-1 imaging. And hopefully toward the end, we are going to start to see that maybe a very bright future for every one of us, what we can do using imaging as part of our work in the immuno-oncology. So in BMS, what we positioned ourselves from the beginning is that we have an end-to-end model of translational imaging roadmap that has a bidirectional nature so that we can learn from the preclinical as well as learn from the clinical reversely. And usually what we start with is that we want to start with a very good fundamental understanding of both the imaging agents that we use, the platform, the characteristics in their molecular, chemical, and biological nature, but also to gain confidence very early on about target specificity. If we have a good specificity of the targets and you have a good platform to go along with it, as you can see, what we typically do is to have a very good radiologic and pathology correlation. You can see in this case of PD-L1, the blue background is the imaging, in vitro imaging of the PD-L1 ligand that we use, and it has 100% correspondence to the IHC, which is the brown and white pictures, both geographically as well as quantitatively. And with that, we bring this concept that, okay, it works very well in the in vitro setting. Let's make sure that it also translates to a corresponding appearance, what we expect to see in living animal. So we typically would then conduct a series of in vivo experiment. As you can see in this case, those are PD-L1 positive tumor versus the PD-L1 negative tumor. Thus, they have different appearance in the living animal to prove that this concept is not just working in the petri dish, but it actually works in animal as well. And with the correct, with the appropriate model to translate into human, we would typically perform dosimetry and safety measures to make sure that we are projecting a correct dose that is safe for human, but also to gain some confidence of imaging timing so we can have the least amount of burden on patient when we conduct these studies. And then we move toward the clinics for that. So using this roadmap, we were able to produce a first study in not just PD-L1, but PD-L1 and PD-1 imaging in patients with non-small cell lung cancer. So together with our colleagues in the Netherlands, we did our proof of concept study. We started with the very clear understanding that the speakers from today as well as from yesterday clearly identified that PD-L1 has prognostic implications. And certainly in many tumors, you can predict response of PD-1 checkpoint inhibitor therapy. But they don't always work. There are certainly incidents that we all experience that patients thought to be PD-L1 negative actually responds, and some people who are actually PD-L1 positive turn out not respond to immunotherapy. Why is that? Certainly one of the reasons that we've been suspecting for quite a while is that biopsy has certain limitations that might not be able to fully articulate the PD-L1 status of the tumors in the setting of heterogeneity within as well as among different tumors. So with that, I'm going to focus only on the imaging part of this trial, particularly on the PD-L1 part of the story first. Because for the PD-1 part, we have nivolumab that we have already a lot of clinical information about safety and efficacy on the patients. But the PD-L1 is actually coming from a new platform called Anectin, which we haven't used a lot in the human in the past. So using the roadmap I described earlier, the first thing we established is that we have a very good understanding of the preclinical safety and dosimetry, and therefore projection of the dose in the human. And with that, we confirm in humans that in fact, this compound is actually 7 times safer than what we initially predicted with the preclinical model, which is a very pleasant surprise. And as of today, I'm happy to report that there has been no adverse reaction whatsoever that we detected with this for the 2+ years that we have been using this agent. Now let's take a look at the compound. It actually has a very high physiologic uptake in the spleen as an internal control. So we know that when we look at the picture immediately, we can tell whether the tracer is doing what we expect to do. Now, the PD-L1 Anectin, as I mentioned to you, is a smaller protein than compared to antibody. It actually has a different excretion mechanism. It actually has a lot of into the kidney as compared to the biliary tract, as in most of the antibody imaging. Now, for this audience, worry not. We also have a PD-L1 compound that has almost no renal excretion. So if you want to look at tumor in the kidneys, we certainly have that covered as well. But in this case, what is very important in particularly imaging solid tumor is the following. This compound has very little uptake in normal lungs and brain. These are some of the biggest organs that have metastatic disease going in solid tumor, as well as a relatively low to moderate bone marrow and liver uptake. Again, these are also organs that are particularly prone for metastatic disease. So in the biodistribution, this agent is very favorable in solid tumor imaging. So the next step we want to make sure is exactly what we did in the preclinical as well, is to making sure that what we see is what we think we see. So we started with our imaging, have a 100% corresponded with the IHC, as shown here in 2 patients. The top patient is known to be PD-L1 positive by IHC, and the bottom one PD-L1 negative. And they have concordance PET imaging with high PET signal for the first patient and low PET signal for the second patient. And from our initial experience, indeed, we got a very good agreement. The patients that are PD-L1 positive, they tend to have very good uptake on the imaging. And the patient has low PD-L1 IHC, have low PET signal. More importantly, we were able to dive down not only in the patient level, but also in the lesional level. And those that are supposed to be PD-L1 positive, and therefore expectation is they are likely to respond to immunotherapy, did. And those lesions that have low uptake on the imaging, they tend not to respond. So again, this is very good correspondence between your expectation and the imaging. But if the imaging merely agree with the IHC, why don't we just do IHC? So one thing, as I mentioned before, that there are people, there are patients who are IHC and the expectation and the outcome of the treatment was discordant, and we have some idea for that. Focus on the patient, particularly on the left-hand side. The patient by IHC was PD-L1 positive, but if you actually look at the tumor, certainly not every part of the tumor that is flanked by these arrows are all the same positive. In fact, the patients have 2 tumors, and they also have very different PD-L1 expectation. And that probably explains part of the reason why some of the patients with PD-L1 positive did not respond to IO therapy and vice versa. But now we have one tracer. Imagine what you can actually understand if we have more than one. So in this case, the same patient, in this case, is a PD-L1 positive tumor. We expect that that this person is going to react to nivolumab quite well. Well, why is that? Certainly, this tumor was able to grow in the patient's body using, at least in part, the PD-L1 as an immune escape. So if you can block this immune escape using, for example, nivolumab, as you can see, you expect the T cell to actually accumulate into the tumor. And in fact, that's what we saw. Then the patient has a very durable response. The second patient is opposite. This tumor is PD-L1 negative. I don't know what the immune mechanism is, but it certainly is not PD-L1. So your expectation is therefore by blocking the PD-1, PD-L1 interaction will probably be not the most important therapeutic handle on this tumor. And in fact, the patient did not respond to nivolumab. So now this is only the beginning. Then we talked about our experience with PD-L1 imaging, and also our colleagues also have their versions of it. But in addition to the PD-1, PD-L1 axis, there's a lot more mechanism that we need to consider, and some of these are listed here, such as CD8 imaging, in which that we actually look at the CD8 T cell accumulation in the tumor. T cell activation, some of it actually even go into further the functional, not just the cell type, but the activation of these T cells. And also in ipilimumab, we want to understand better how this accumulates. And we have some initial human evidence. Some of the results are actually quite interesting. For example, the spleen here doesn't light up all that much. But these are just a little bit of examples. I hope what the message we can understand is that we talk a little bit about how certain drugs and certain targets, they interact. We talk about having the entire pathway rather than just one side of the pathway, tell you a lot more about the mechanism and the concept of immune escape. We can actually even go further than that, including and not limited to multiple tumors and multiple pathways. We are now entering combination therapies. Also, most of these markers are alive. They are not like our social security numbers. Once you have it, you stay with it for the rest of your life. They can change. So seeing at different time in the therapy how this marker might change will gain you a lot more information than just a single time point. And of course, we also can have it in more quantitative manner, and also we never forget about safety and toxicity. If we can use these imaging techniques to help us to understand some of the untoward effects throughout therapy, that can also help our patient that way. So with that, I want to thank you. Particularly, I want to thank our patient who really what we are trying to help, and with you in the background supporting them to make their life better every day. Thank you.
So thank